Welcome to Care Chats. Join palliative care experts sharing stories, information, and strategies. We're passionate. Join us, and let's get comfortable with palliative care.
Welcome back to Care Chats. My name is Brooklyn, and I'm a palliative clinical nurse educator. I am joined today with Danica, a education lead from the Palliative Institute, and Jen, our lovely palliative nurse consultant from the University of Alberta Hospital. We are a group of palliative care nurses who are all trained on an acute tertiary palliative care unit and are passionate about providing palliative care and educating healthcare providers to do the same. We would really love if you could take a minute to fill out our feedback form, linked in the description below. As well, on a future episode, we'll also be doing a mailbag and answering any questions that you might have about palliative care. So you can either comment below or submit a question in that feedback form. It would be greatly appreciated. If you haven't watched our first two episodes, be sure to check them out. And on this episode, we are going to talk about how to care for the patient who is imminently dying. To start off, we got to know what would be some signs that we're looking for when somebody is imminently dying. So typically in the last few weeks, we will start to notice someone will have a decreased level of consciousness. They may become more drowsy and eventually will become unresponsive. We also might notice that there'll be decreased intake. They might not want to drink or eat. And then as we get into the last hours to short days, we'll notice some decreased output, especially urine. With the catheter, this is definitely easier to notice. We also might notice some changes in their breathing patterns. Respirations can become irregular and vary from tachypnea to chain stoking or agonal breathing, which is usually a late sign. Some other changes we might notice are changes in their temperature and skin color. People might often have fevers, feel hot or clammy, or they can also feel really cool. Mottling, which is a dark kind of purple splotchy discoloration, also starts, and we notice this typically on the feet and hands, as well as the lower limbs. We also might notice that the patient becomes more pale. They might have dusky colored nail beds, lips, or mucous membranes.
Brooklyn, do you mind describing chain stoking respirations?
So, chain stoking respirations are where there is a lot of rapid breathing followed by pauses in their breathings.
And on the topic of changes, frontline staff might notice that at the end of life, there can be changes to vital signs. So, things you might notice, maybe their blood pressure drops or an increase in heart rate, irregular respirations, as Brooklyn so kindly pointed out, and then decreased O2 sats. Keep in mind these changes can be a very normal part of the dying process. At the end of life, vital signs are often discontinued. I know we talked a little bit before about how it's possible for patients to die if their goals of care is M1, which involves more active medical intervention. So perhaps we would notice changes in vital signs, but hopefully we would be able to prepare for death enough that we won't expect to take vitals. But those might be some things that we notice. Rather than focusing on the number or the value of those vital signs, which doesn't necessarily indicate comfort, we would need to assess our patients and focus on how they're presenting to determine if they're comfortable. So if they're symptomatic, we can intervene with appropriate interventions, but we don't necessarily intervene based on what the number shows. Can I also add that at the end of life, particularly if it's an expected death, for family who like to know what the vital signs show, for example, heart rate, or lots of people are really stuck on oxygen saturations. One point of teaching that could be done is that those numbers are going to get more abnormal with time. And so sometimes if we're checking and we're monitoring, it just kind of causes more anxiety and it makes us want to do things and intervene, even though there's no reasonable intervention that could reverse the cause of what's happening.
That is a very good point. And so, on that note, what are some things nurses or frontline healthcare providers will want to do or assess for if they suspect their patient is imminently dying?
Well, when any member of the healthcare team thinks their patient might be actively dying, which means they think that that person has hours or maybe days to live, there's a few first steps. And I think the very first thing that they should do is talk to the team. So let your charge nurse know or your HN know, let the MRHP know, and talk to the people who are caring for that person most often. So let the healthcare aides know, let the LPNs know, let the nursing team know so that you're all on the same page. And then you can take a bit of time to talk about what you're noticing. Why do you think that person is imminently dying? And everyone can sort of go through those changes together. And then you have a baseline as well, which is good for going forward. And then the next step is probably to review the legal documents, primarily making sure that you have a contact for either the main family member or the alternate decision maker, so that you can make sure that you know who to call if things change rapidly. And then you can also take a few moments to see if there's any documented wishes, either in the tracking record, which we talked about last time, or in the goals of care designation, if there's any end of life wishes or spiritual customs that have been noted. All of that information is good to have as soon as possible. So anyone on the team could take some time to have a conversation with the patient if possible, or you can assign someone that it might make the most sense for their role. And then ask them if they have any specific needs related to end of life and dying. It's okay to be straightforward, like we talked about in our difficult conversation episode. Just ask the question straight up. We've noticed that these changes are happening. We can tell that this person is getting closer to the end of their life. Is there anything that you really need to know? Or is there something that you really want to do? Or is there someone that really needs to be here? So asking straight up and not being too vague will really help the patient, the family, and the whole team know that everyone is on the same page. And then it's also okay to say, I don't know the answer to that specific request or question, but I'm going to find out. And then make sure that you follow up with whoever is the most appropriate person on the team to make sure you get an answer to whatever the patient and the family are asking for.
Also important to ask if they're registered as an organ or tissue donor, or if they have a funeral home picked out, and what the contact information is for the funeral home. If the site has a morgue, the family is generally responsible for contacting the funeral home, but make sure you know the process at your site. Some sites will do the calling for you. Some sites will require the family to kind of organize that part.
You can also consider using the White Rose program poster, which is available across the province and in some other areas across the country as well. And this is to signal to other staff that the patient is close to the end of their life. It also comes with a caregiver resource information sheet, and there's lots of information for caregivers that you can find on the palliative and end of life care website of Alberta Health Services. And there's also a provincial bereavement package that's available that is very handy to hand out to families, even before the person has died, if they are asking questions or they want something to do. Sometimes they're sitting around for multiple days and they want to be busy. So you could give them a bereavement package and they can start looking through it, emphasizing that it's not a priority and that they don't have to do anything before the person dies, but that they have that option if they want it.
I will say I'm a list-based person, so I really appreciate the bereavement packages because it gives you that list of people to call and notify after death.
Totally. There are also many opportunities in those last hours and days to set up the patient and the family to be more prepared and to be less anxious. So again, we talked about this in our last episode about difficult conversations, but the more information that people have generally will lead to better communication and less conflict. And then you can also consider if there are a few small comforts that you can put together on your unit to offer families who are actively dying. So I've seen some units that have comfort baskets with instant coffee or individualized snack packs, or they have volunteers who make blankets or things like that, that it's just a nice little touch, something extra that you can give to those families.
Yeah, those are some really great ideas and things that we can incorporate into caring for the patient and their family when they are initially transitioning to end of life care. Some of these tasks may be delegated to another member of your healthcare team, such as referring to spiritual care to help facilitate any end of life customs or practices, or you might need to reach out to social work if there's any legal or financial needs that need to be addressed. And remember that palliative care is best done when there's collaboration amongst your team members to address all the needs of your patients and their family. So, how do we assess and care for a patient who is imminently dying?
So once the desk jobs are done and the paperwork has been reviewed and everyone's on the same page, and all the tasks have been delegated to the right person, nurses need to continue to assess patients right up until the moment they die. And it's going to be different, obviously, than a traditional head to toe or a head to toe, whatever that means on your unit in your area, because we want to maintain dignity and comfort rather than curing or extending life. So we may have to consider the person's goals of care. Like Jen already said, people die with any number of goals of care designations, so that also needs to be considered. But we want to make sure that we're still providing care that's aligned with their wishes, that provides dignity, and that we're looking at the whole person. So, some of the major things to focus on, first of all, is assessing the person's pain, making sure that they are comfortable, that they're not experiencing pain. And one of the things to keep in mind is the route of their pain medication. We might have to consider switching from oral to sub-Q, or if they already have established IV access, sometimes that's a good option too, because they will get more drowsy and eventually lose consciousness.
Question for you guys. If the patient was unable to verbally express that they're in pain, what are some signs that a nurse would want to look out for that might indicate the patient is in pain? And are there any tools that we can use to help with this assessment?
Definitely. There's lots of nonverbal signs we can look for. So the classic ones are grimacing, a furrowed brow, moaning, resisting care or guarding a specific part of their body, increased rest rate, or increased sweating. And also consider what your patient was feeling before they became unconscious. I think that's usually a really good sign. If they've had leg pain for the last weeks or months or years, we can assume that that leg pain is still there.
Yeah, we can use some tools to assess for pain if they can verbalize. So that's your OPQ-RSTU or the scale from 0 to 10, for example. If they can't use the numerical scale, they can use the face scale option. If the patient can't rate their pain, maybe using the pain AD tool can to assess for pain with a patient with cognitive impairment might be helpful. Yeah, I like, Danica, what you said about knowing the history of that patient's pain experience because lots of people at the end of life, particularly where we worked, they end up on a very scheduled dose of opioids for pain, for example. And some nurses might consider holding that pain medication if the patient looks really relaxed and comfortable at the time. But the risk is that if, knowing that the patient required that scheduled dose of opioid before, we can only assume that they will still require it as they are actively dying. So it would be beneficial to keep up with that schedule and not be holding doses just because you're not getting a response from the patient.
It's a
That
really
is
good
such
point.
an important point. Yep. So once you've assessed pain, you can move on to another very common symptom, which is dyspnea, making sure that they're breathing easy and that they're not verbalizing difficulties in breathing. Remember that dyspnea is subjective, so ideally it's coming from the patient's mouth that they are feeling that symptom.
That's a really good point. Sometimes you have to make sure you're explicitly asking if they're having difficulty breathing. They could be experiencing the sensation of breathlessness without any actual outward signs. And as of a note, going back to vital signs, oxygen saturation values do not always indicate if the patient is short of breath or not. I've had patients where their saturations are 100% and they still are experiencing that sensation of dyspnea. And then I've also had patients with oxygen saturations in the 70s or 80s, and if you ask them if they're having a hard time breathing, they'll tell you no. So just to keep in mind that dyspnea is very subjective, and you do have to ask them if they are experiencing that.
If your patient is not verbally responsive, like if they're really labored respirations or if they're really tachypnic, I know I've seen nurses in the past intervene with PRN opioids for
Mm.
that to help kind of calm down the breathing.
Opioids can be used to help with dyspnea, but what are some other things that nurses can do to help with dyspnea?
Certainly, dyspnea can be linked with anxiety. Like oftentimes, people might feel more panicky if they're more dyspneic, and then the panic kind of feeds into the dyspnea and vice versa. If they're at home, opening a window might be helpful just for that fresh air. If you're allowed a fan, I know some of them aren't allowed in hospital, but if you're allowed a fan, sometimes just that air in the person's face can be really helpful. Oxygen for comfort is an interesting one. I'm not sure there's any evidence, like Brooklyn had mentioned, that oxygen will necessarily help with that sensation of dyspnea, because oxygen might help with saturations, but it might not help with the actual sensation, particularly if your patient's in the very last hours to days of life. Mhm.
I will say that I have had some patients where just that feeling of that airflow from the nasal cannula does provide that like comfort and that feeling of like almost like a fan blowing, or that sensation of like fresh air if you are in a hospital and you can't open the windows. So while it might not actually help entirely with oxygen saturations, it could definitely help with comfort. Really patient dependent.
Very patient dependent, and definitely want to talk to the family. If the patient's able to talk to you about it, then might be worth exploring. But if they're not and they're actively dying and they're unresponsive, maybe worth talking to the family about their values in the situation and priorities, because oxygen can be perceived as a life-prolonging intervention as well. Again, making sure it's really in line with what the patient's wishes would be.
Definitely, very good point.
Another thing we want to assess for the patient is that they are calm and settled, which kind of feeds into what we just talked about. We want to make sure that they're not feeling anxious, that we can assess for nonverbal cues of distress and anxiety, like restlessness, picking at the air, or twitching. Deliriums are also super common at end of life and can cause extreme distress for the patient and also for the family member or whoever's in the room watching them. But we have lots of options to deal with that.
Oh boy, do we. Usually something like an antipsychotic or anxiolytic for agitation. Some people might order a benzodiazepine, but that can be a little bit, it can be situation dependent, because sometimes benzos can worsen delirium for some patients. But keep in mind that we generally refer to hyperactive delirium as agitation, but there's also a different kind of delirium which is hypoactive, and we can maybe get more into that in a different episode.
That's a good point. And sometimes at end of life, it can be also hard to determine if the patient is experiencing pain or agitation. A lot of these symptoms kind of mimic each other. So a kind of a little tip is that if you've given a few breakthroughs of pain medication and it doesn't really seem to settle the patient, you could always try an antipsychotic or an anxiolytic to see if that helps settle the patient. It can definitely make agitation or the delirium worse if we're just loading up on the opioids, which also isn't great for the patient or the family.
Another thing we're going to assess for is how the person is breathing and if they have noisy respirations or secretions. So, one of the things we want to consider is if they're still receiving artificial hydration, we might want to talk to the MRHP about that. But we could also consider more frequent repositioning and medication for very severe cases.
Yeah, we might consider some medications such as an anticholinergic, like I'm sure you've heard of glycopyrrolate or scopolamine that can be sometimes be used.
Definitely. Sometimes also I've had some staff ask me if they can suction, or I've even had families ask if we can suction those secretions out. And generally, that's not really recommended at end of life, as it can be more harmful than it is helpful. While it could maybe potentially temporarily relieve the noisy breathing associated with secretions, it can also increase discomfort and potentially actually worsen the situation by stimulating more secretions and damaging the delicate tissues. So while deep suctioning we tend to avoid, there could be some benefit, especially if those secretions are quite prominent in the mouth. Then, yeah, you might want to do some oral suctioning just to kind of get rid of those secretions and do some really good mouth care in that situation. But I would not recommend deep suctioning.
Yeah, that brings us to another point that we should assess that the mouth is moist and clean. So it's very important to make sure that mouth care is being done regularly. Every 2 hours is ideal, but I generally will match it up with when I'm doing medication administration or when I'm going into the room for another reason. So it's just another thing that I can do while I'm asking everyone if they're okay or if I'm assessing the patient for any of the other symptoms we're talking about. And if there's someone sitting at the bedside that wants to do something, I'm showing them how to moisten a swab and keep that person's mouth moist and comfortable is a really easy and simple way that they can make a big difference.
For sure. I would agree. Mouth care, it seems like it's such a small thing or it's like on the bottom of the priority list, but when it comes to end of life care, it really can make a huge difference. A lot of these patients, their mouths can become really, really dry because of the medications or treatment side effects. They're dehydrated. And so providing that really good mouth care using, gentle toothbrushes or toothettes, making sure their lips are moisturized, all of that can really make a big difference, not to just the patient, but also the family that are there at the bedside as well.
That's a great way to get families involved in the care and have them have a
Mhm.
more active role in the process. We'll probably get into this in a different episode too, but I find lots of families get hung up on the idea that the patient's not eating or drinking anymore,
Mhm.
especially in the last hours to days of life, like they're just too weak and too drowsy to eat. So providing mouth care sometimes can kind of mimic that task, right? It gives them
Mhm.
something to do to focus on.
Totally. And that also brings us to another thing we should assess, which is nausea and vomiting. So we want to ask the patient if they're feeling nauseous, if they can answer, but if they're not answering or they're unconscious, then we can definitely look for evidence of vomiting.
And also similarly to what we said about pain, and probably it would apply to dyspnea as well, as if the patient historically was really nauseous and required around the clock antiemetics, then it would be worth continuing that schedule, even though the patient does look really like drowsy and relaxed in the moment. So the antiemetics that we like the most in palliative care, any guesses as our top choice for antiemetics?
Maxiran.
Woohoo! I don't know if that's an outdated brand, but everybody
Yeah.
refers to it as Maxiran. So,
I guess the other
um,
term, metoclopramide.
yeah, that's what people might notice most often if palliative
Mhm.
care is providing consultation or care to the patient is that they'll be on a good dose of Maxiran.
But even another trick question, what situation do we not want to use Maxiran in?
Complete bowel obstructions.
Yeah.
In cases of complete bowel obstructions, we try to avoid a prokinetic because that would risk perforation. So you might find that your patients are on an antiemetic, such as an antipsychotic like Haldol or olanzapine, sometimes even Nazanan, depending who the prescriber is.
Another thing that we should be assessing is skin integrity. So we think about the regular skin integrity things like pressure ulcers, reddening and wounds, but also sub-Q sites and IV sites is a really big one at end of life. If you're giving lots of meds around the clock, you're keeping up with symptom management, making sure that you're assessing the skin around medication administration sites, and doing frequent repositioning using wedges, pillows, and other aids, whatever is available at your site. Um, the recommendation is to consider repositioning every 2 hours. Another trick that I use is also to do repositioning when I'm doing medication administration. So you're in there generally at least every 4 hours. And that just helps to minimize the disruptions in the room and whatever calm is happening with the patient and their family.
Mm. Yeah, sometimes families or even I've had some nurses be a bit hesitant to reposition a patient at end of life. There's definitely a balance between comfort as well as pressure injury prevention, as these patients really are very high risk for skin breakdown. But repositioning is an essential part of kind of hopefully reducing that risk of more pressure injuries. There's more risk of pain involved. So we definitely, while the focus is comfort, still want to put in interventions to reduce pressure injuries. So often when I have families that are maybe a little hesitant for me to reposition their patient, I do start with asking them if there's a reason behind their answer. Maybe curiosity of sometimes they might just be concerned that the movement will cause them pain. Or maybe they had a really uncomfortable night and the nurse on nights finally got them settled and they're actually comfortable for a little bit. So I still will gently provide education on kind of the importance of ensuring comfort, but also reducing the risk of pressure injuries because we don't want to cause more pain. And then maybe offer some alternative suggestions. So as Danica mentioned, maybe we time the repositioning around when they got a pain medication, their scheduled pain medication, or we can accommodate the family and come back and reposition them later, asking them when would work best. Again, including them in that care, allowing them to make that decision really helps foster that relationship with your family that you're caring for. But also keep in mind that these repositionings don't have to be really big. They can just be small movements, even slight adjustments, whether it's removing a pillow or sliding a pillow somewhere else. Those small positions can help as well. But ultimately, if after having a discussion with the family and providing education, offering alternatives, the families still don't want the patient repositioned, that's okay too. We always do the best that we can.
Brooklyn, what would you say to someone in a similar vein who requests that their family member not get any personal care, like their bed bath or to be washed or changed for the same reasons? They don't want them to be disturbed or it's going to cause
Mhm.
pain.
I think that's a really kind of along the similar lines is always kind of be curious about why, because that will provide you some insight onto the reason behind. So maybe it is providing them a little bit more education. But I think it is just kind of reinforcing that caring for their personal needs, it maintains their comfort. It allows us to check their skin to make sure that we're not causing more pain, any of those types of things.
That's a great answer. I also think that if we can do bed baths and skincare and personal hygiene needs, it can also allow us to provide dignity and comfort for the patient. Like if you talk to the family member about, like maybe I can brush their hair and I can maintain that part that they've had for the last 75 years of their life. Like they'll look more like themselves.
Hmm.
Or I've also had patients that wanted to put on lipstick or they put blush on every single morning. So even though they were unconscious, I would still wash their face. I would still put on a little bit of blush for them. And the families were like, wow, they look so much more like themselves now, and it's not as jarring that they're dying and they don't look like a dying person. They look like themselves. And that can make a huge difference.
Another little trick, if you want to talk about kind of providing a little bit more patient centered care, is and making them seem more like themselves. A little trick that I remember learning is if the families are okay with it, if they have their own personal shirts that they like to wear, and they're willing to allow us to cut the back of them. That way, they don't have to wear a hospital gown necessarily, but they could actually wear some of their own clothes. So again, getting permission from family first. But I always found that families were really appreciative of that if they were willing and accepting of us cutting up the clothes. Hmm.
Yeah, that's been really effective in the past. Hey, like you just have to
Hmm.
put the shirt through, like its arms and head through the shirt, and then the back
Hmm.
is just kind of open.
Hmm.
I love that.
Yeah.
Another thing we want to assess for people who are actively dying is we still want to make sure that their elimination needs are addressed. So the guideline here is to make sure that people are having a bowel movement at least every 3 days, and then also assessing for signs of urinary retention, utilizing incontinence products as needed, and also a catheter is usually a good comfort care intervention towards end of life.
Yeah, there's always a little bit of confusion, maybe even disagreements when it comes to bowel care and catheters at the end of life. We do find, I mean, some people don't want catheters, and that's okay. We do find catheters kind of can help prevent even some agitation related to wanting to toilet or that urge, that frequent urge to void. And the same thing with bowel care, right? Like it is specifically mentioned in the nursing assessments of the C2 pathway to assess every 3 days and provide a suppository or enema if you don't have a BM. Even if there's no PO intake, there could still be some stool produced from mucosal shedding or secretions or the even just like the bacteria content in your bowel, in addition to any residual stool in the bowel from when the patient was eating. So perhaps some things to keep in mind at the end of life are, how close is the patient to death? Whether they're experiencing any signs of discomfort related to the constipation, what the family or patient wishes would have been. I've had patients before who historically have been obsessed with having bowel movements, and to have them go 3 days without a BM would be torture. So you kind of, right, that would help kind of guide
Hmm.
what you would do. And then again, like I said, agitation, like if they're climbing up out of bed and they're unable to tell you why, we want to make sure that they're not just trying to get to the bathroom to poop. Are we allowed to say poop on a professional podcast?
We're nurses, we could do it.
We want to make sure they're not trying to get out of bed to have a bowel movement, and then we're just sedating them with medications instead. So it's just really important to eliminate that as a cause for agitation.
Yeah, to address those basic needs first before we jump to the medications.
Another thing that we want to make sure we're assessing right up until the end is the psychosocial and spiritual needs of the person. So, obviously, when they're awake and they're alert. We can ask them what their mood is like. We can ask them about what their wishes are regarding visitors, including pets. So you should check with your facility what the pet policy is, because generally we can allow pets in for visits, especially for palliative and end-of-life patients. And then we want to make sure that we're always talking in a calm manner, that we're using gentle touch, that we're being respectful, even when the person isn't responding to us. We don't actually know what they're hearing, what they're feeling. Just because they can't say it, it doesn't mean that they don't know that we're there. And so I think it's really important to emphasize that we need to be respectful and kind and caring right up until the moment that that person is passed away.
That's a really good point. I always like to use the patient's name still. I kind of explain what I'm doing. Hey, Mr. Smith, I'm just here to give you your pain medication. Hey, Mr. Smith, I'm just here to flip your pillow, give you the cool side. All of those things just to continue to talk to them in a very dignified and respectful manner.
And even, I know you said, Danica, until the moment of death, but even after death, right, to make
Mhm.
sure you're referring to the patient by their name when you're talking to the family.
Mhm.
Yeah, I think that's an excellent point. We'll talk about after death care a little bit more in our next episode, but that is a really good thing to keep in mind. And then the last thing really to consider is the family's needs. So making sure that you're taking time to listen and respond to their questions. They will probably have lots of worries and fears. Most people don't watch. Many people die in their life. They don't know what to expect. They don't know what it's going to be like. So it's important to keep that in mind when you're going into their room. Referring to the interdisciplinary team and whoever is available on your unit to ask or answer specific questions or specific needs. We already mentioned spiritual care, but social worker also can be very helpful towards end of life for specific questions. And as mentioned in our difficult conversations episode, it can be very useful to use clear and direct language. Another thing I like to do is provide opportunities for reminiscing and asking questions. So if I'm doing a bed bath and someone is sitting at the bedside, I might just say, "Hey, tell me about your favorite memory of this person in the summer. What did you guys love to do together in the summer?" And then the person who's sitting there can just share their story. It kind of lightens the mood, and you get to learn something new about your patient. And it's a good way to also connect.
Yeah, for people who have been married for a really long time, it's always my favorite to ask what their wedding day was like.
Mhm.
Oh, that's a
Oh,
great
that's a nice
question.
one.
Bonus points if they have photos.
I feel like we could talk again all about how to care for the families and some really good tips. And so in our next conversation, or I guess episode, we will definitely talk more about how do we support families, how do we answer some of those common questions.
Actually, there is one more thing that we should talk about and mention when we're assessing end of life care, which can sometimes be a hot topic, but fluids and food at end of life. So I think the first thing to consider is the person's preference. So if they do want to eat and drink, we should support them. And if they can safely do it and they're awake, and also encouraging people to eat and drink what they want. You can also consider eating for comfort. There's a great pamphlet on the POLC website. And this also touches on providing meticulous mouth care, which we've already talked about. In Brooklyn very uh, gave us lots of details about. But monitoring hydration status is also an important part of end of life. And artificial hydration can be beneficial in some cases, for example, to decrease the risk of neurotoxicity. But there are also some side effects that could cause harm, like edema or increased respiratory secretions. So it's a fine balance for sure.
Yeah, I wonder if maybe the question to ask when considering hydration in the last days of life would be, is the hydration answering the question of what symptom are we relieving? Because if your answer is no, I'm just providing hydration for general comfort, then maybe we're unnecessarily prolonging suffering or perhaps adding to discomfort by risking fluid overload. One final little mention in terms of end of life care is that we might Occasionally, in extreme situations, you might be caring for a patient undergoing what we call palliative sedation. So, this is a process by which the patient is very purposefully and deeply sedated for the relief of refractory symptoms. So, you know, in layman terms that my brain can understand, it's we've tried everything else in terms of medications to relieve these symptoms, but nothing is working. So now we're at the last resort, which is to make sure the patient is deeply sleeping and not experiencing that pain as much as possible.
Mhm.
And so that's called palliative sedation. It comes in a few different forms, and we'll definitely discuss this in more detail in another podcast episode.
Yes, that's a great topic to talk about in the future. We definitely rely on a lot of medications when we're caring for somebody. There's a lot of symptoms that patients have at end of life, and so we do need to use medications. But if those aren't working, there is always another alternative and something more that we can do. So that's always reassuring to the families as well. If they feel like there's perceived suffering, there's definitely more that we can always do for the patients. So thanks, Jen, for that. Those are some really great points. A lot of the information we covered today is explained in the Care of the Imminently Dying Pathway. And if your site is using ConnectCare, you can also find additional details in the row information section when using the Care of the Imminently Dying flow sheet. But this might be a good point to end our conversation for today. Thanks for joining us today on this episode. And we hope you learned something, a thing or two to take away. But anyways, for now, take care and bye for now.